Okay, so actually, this is, to be honest, this is research that I was involved in because of a colleague, Giuseppe Loria, asked me to be part of a big consortium, which was called the Propane Consortium, which was a big European-funded grant, where we took a big cohort of people with painful neuropathy, without painful neuropathy, with diabetes, from Germany, from the UK, Manchester. We phenotyped them in detail, and then we looked at their genetic markers, right? And by genetic markers, you can look at lots of things. You can look at methylation, you can look at epigenetic gene changes, and it was done because I honestly believe right now, many of the treatments that we use for diabetic neuropathy are, they're 20 years old, right? 30 years old. We are relying on drugs that weren't really originally developed to target painful neuropathy. They were actually used in epilepsy and other things, but they worked, are antidepressants, for example. So we believe that maybe we need to look for newer mechanisms, and that's where we did, and we actually did some detailed assessment from blood samples, from large cohorts of patients with painful and painful, and we found that actually, there were markers like, say, telomere length, and there are about 5 or 6 other markers. There are plasma markers. There are changes in T lymphocytes, changes in granulocytes, which are different if you are older. Now, there is a double-edged sword here, because is it that people with painful neuropathy have these accelerated markers of aging, or is it because they've got painful neuropathy, actually, because of the suffering that they get, they age faster? We don't know. So and so therefore, going forward, yes, those markers are there. Whether or not that will be clinically relevant for the development of treatments, I'm not so sure. And again, with the DNA methylation experiments, from pretty much the same cohort, we showed that there were 2 or 3 genes that were hypomethylated, not hypermethylated, hypomethylated, which differentiated people with painful from painless diabetic neuropathy. So, yeah. So, well, I've been involved a very long time, actually. So, in fact, my first introduction to diabetic neuropathy was when I was a medical student. A long time ago, right? 30, 40 years ago. And I've actually kept in that field. Why? Because, one, I believe there's a lot of work to be done, right, in this field, and particularly, say, painful diabetic neuropathy. So, we know that most European, US studies will tell you that, 20%, 1 in 5 individuals with diabetes will have painful neuropathy. But actually, when some of our work in the Middle East, in the Gulf region, has shown that prevalence is much higher. So it's like actually 35, 40% of people have got painful neuropathy. What is painful neuropathy? Well, painful neuropathy is when people get burning pain, they get numbness in their feet, and it has an effect on their sleep. It can give them depression. So it's really, people don't realize that, how bad it is. But and unfortunately, also, we don't have, I would say, in clinical practice, we don't ask the questions that we should be asking, just to simply pick up that whether or not patient has painful neuropathy. It's a little bit like, I always go back to when before treatments for erectile dysfunction, right? Before Pfizer came out with Viagra, nobody in the clinic used to ask about erectile dysfunction because you didn't have any treatment. Okay, then suddenly that whole thing changed, right? And painful neuropathy, again, I think is a little bit like that, in that treatment is, I would say, moderately effective. Right? Moderate. So therefore it makes, and diagnosis can be very easy. I only have to ask a question. I have to say, do you have pain in your feet? Is it both legs? And is it worse at night? And that actually is probably sufficient to diagnose painful diabetic neuropathy.
I want to know the next if I'm the patient.
Sorry?
If I'm the patient, I would like to know the next. What should be done to treat my symptoms?
Yes, yeah. And so then we have medications that are currently, should we say, FDA approved. And these include, things like pregabalin, gabapentin, duloxetine. But we all know as clinicians that they are moderately effective at best. You know, they are effective, they work, but I always say to people, if I have a headache, I take paracetamol, okay, I take Nurofen, and the headache goes away, right? But actually painful diabetic neuropathy, when we give many of these medications, most patients, only about half of them will get 50% reduction in pain, so which is not really that great. So we need better, newer therapies, I think, first of all, and maybe in different mechanisms of action. And we also need to diagnose painful neuropathy better. What causes it? You know, well, we know that it is signals, abnormal signals that come from something called small nerve fibers, right? Which are nociceptive fibers, they're called. Now, if I am diagnosing diabetic neuropathy in the clinic, I actually don't even do any of those tests to look for small nerve fiber damage. We use the monofilament. We use reflexes. These are testing the large fibers. They have no relevance to small fibers. And that is a big issue. And that's actually something we've been working on. So we have a technique called corneal confocal microscopy. All right. I know it sounds like a big mouthful, but actually it's a really simple technique which scans the eye and is able to image small nerve fibers. And now we have AI technology that is able to just like within seconds, minutes, tell me if there is damage and you know what kind of damage it is. And interestingly, because this is a Chinese audience, actually there have been more corneal confocal microscopes sold in China than anywhere else in the world recently. And it seems like there's a big interest of using CCM in particularly the top centers for diagnosing, for using it actually for diabetic neuropathy, but also other neurodegenerative diseases. So for example, we've done work on Parkinson's disease, in dementia, and we now have AI-based ability to be able to diagnose these different neurological conditions. So I think actually there's going to be, for the better management of painful neuropathy, we have to get cleverer as clinicians, right? And you know, everybody talks about personalized medicine, right? But do we practice personalized medicine? No, because what happens in the clinic is I get a patient who comes in, and if I'm really doing a good job, I will diagnose them. I will say, okay, you've got painful neuropathy. But then I just say, okay, all of them have got painful neuropathy. But we know that individuals with painful neuropathy, actually, there are different subtypes within that, probably 3 or 4 different subtypes, but we never bother to, how should I say, subtype them. And I think there are now methods available that where we should be doing this. We should be not only diagnosing them, but actually say, okay, you know, you've got this particular type of painful neuropathy, and that's going to respond better to drug A or drug B or drug C. And it could be that we have tests actually now where you can say that, okay, you're going to respond better to duloxetine or to pregabalin and gabapentin. And the difference is huge, actually. So, you know, you can get a 30% response in some patients with a particular drug, and using the same drug in a different subtype of neuropathy, you get a 70% response, right? So that to me is something we need to do. And then in the pipeline, there are new drugs, and there's actually one drug, again, it happens to be from China, crazugabalin, right? Which is you could say it's the grandson of pregabalin or gabapentin, right? And it's like 23 times more effective at what it does. And it's being actually approved by the Chinese FDA, but not by the FDA. They're doing clinical trials in the US, but that looks really promising, I think, because it's a very rapid onset of pain relief. And that's the other thing. You know, a lot of these drugs we use, it takes 2 weeks, 3 weeks for the pain to get better. And often the patient kind of thinks, you know, should I carry on taking this or not? So this particular drug, within like 2 days, you get an effective pain relief. So that's the old drug, like it's been manufactured, well, maybe developed in a better way. And then there are new mechanisms of action. So there are voltage-gated sodium channel blockers. So 1.8, 1.7, which are now currently in clinical trial. Recently, FDA have approved for acute pain relief. And there are ongoing trials for painful diabetic neuropathy at the moment. And there are actually a whole bunch of, there's 4 or 5 different new mechanisms of action, which is great for us because as clinicians who deal with this, you know, we've been, as I said, the last drugs to be approved were 30 years ago. You know, the likes of pregabalin, gabapentin, gabapentin has never been approved. Pregabalin, duloxetine, I think it's like 1984 or something, or 94. Yeah.
Yeah.